that for the video. So one of the questions we get is, what about pain relief for patients after surgery? Pain relief for patients after surgery. And we want to talk about anesthesia. We want to talk about analgesia. We're going to talk about some hot new research, and I'm under the gun today because I'm looking down the barrel of a pharmacist. So if I start saying wrong things about drugs and things like that, he's going to say, like that guy who was in the thing when Obama was talking, he said, "You lie!" I'm going to have to be careful here. So, we're going to talk about that. We're going to talk about some new areas of research, which is opioid-sparing analgesia. Opioid-sparing analgesia. We're going to talk about drugs that affect different parts of the brain for pain relief. And so we have a lot to cover. It's a really interesting topic, and there's a couple of good questions and answers in there, so I appreciate your question. But most of all, I appreciate the opportunity to talk because, anyways, so when our patients go to sleep, when they have surgery with us and have anesthesia, that's dangerous business. Putting a heavy person to sleep and waking them up can be deadly. Okay? Anesthesia, although it's wonderful, carries significant risk. And particularly, going to sleep as a heavy person who often has underlying lung disease, maybe sleep apnea, maybe diagnosed or undiagnosed. They may also have obstructive lung disease of other types. They can have asthma. They can have underlying diagnosed or undiagnosed heart disease. They can have arthritis so that they maybe can't move their neck and jaw as much to open up the airway. They have extra tissue up here, so the airway tends to collapse because they have extra tissue and blocks your ability to move air. So surgery in an obese person, potentially very dangerous, and we do, I think, a spectacular job of focusing on that danger and protecting our patients from it. And so I'd like to talk about that for a minute and kind of emphasize the safety measures that we take to protect our patients. Now, around the world, the #1 anesthetic for doctors giving patients anesthesia for surgery is a gas type of anesthesia. The very first anesthesia was in the 1860s in Massachusetts, where they had ether. And ether was on a big cone, and they dripped ether on it. Those of you who are old like me, maybe you had your tonsils out, where you breathed in ether, and they said count back from 100, and you went 99, and then you woke up looking for ice cream, and all you could do was throw up from the ether. Okay, gas anesthetics have advanced since the early days of the explosive and flammable chemical called ether. And so nowadays, almost all anesthetics, probably over 90% of general anesthetics, include a gas anesthetic. That's a variation on the chemical structure like ether. And the gas anesthetics are terrific. They're powerful anesthetics, but they have two complications. One is very unpleasant, and one is potentially deadly. The unpleasant complication is about 1 person out of 3 who has a gas anesthetic will wake up with severe nausea and vomiting. And that's unpleasant, but not deadly. The other complication of gas anesthetics comes from the chemical fact that they are fat-soluble chemicals. Some chemicals are water-soluble, and some are oil, fat-soluble, and oil and water don't mix. Gas anesthetics are uniformly fat-soluble chemicals, and when you breathe them in, some of it will dissolve into your fat. Some will go in the blood to the brain, and when it does cross the blood-brain barrier, great anesthesia. But during the case, as time passes, some of the chemical will dissolve into the fatty tissue. And when that happens, something bad can happen post-op. Because when they turn off the gas, one of the attractive features about it is the patient wakes up quickly. That's good. But one of the disadvantages is that some of the gas may be stored in the fat. So the patient may be awakened, may talk, may go to the recovery room, and then the chemical can sneak back out of the fat into the blood, causing an unpredictable and unexpected respiratory depression, low oxygen, irregular heartbeat, and occasionally death. So we don't like gas anesthetics. So we use a different kind of anesthesia called propofol and remifentanil, very short-acting, anti-nausea type drugs that are very good for our patients and protect against those two complications, severe nausea and vomiting and respiratory depression from the gas anesthetic. Now, when our patients wake up, for the past several years, we would give them pain medicine, and we got asked what drugs we use. We used to use fentanyl and Demerol and Dilaudid, narcotic drugs for pain. The problem is narcotics have two big complications in the perioperative period. And those two complications should sound familiar to you, because one is severe nausea and vomiting, and guess what number two is? Respiratory depression, and exactly like the gas anesthetics. So there's a whole area of research that we have focused on called opioid-sparing analgesia, drugs that release and help block pain without being narcotics. And so in our patients, all of our patients get a combination of drugs to help decrease pain and decrease their needs for narcotics because of the side effects of the narcotics. So our patients get low-dose ketamine, an old drug, which is an N-methyl D-aspartate receptor drug, and then we give Presidex. Presidex, are also called dexmedetomidine, is an alpha-2 central drug. We also give a preoperative patch of clonidine, which is an alpha-2 drug. We also give a preoperative dose of gabapentin, which is an NMDA receptor drug. Plus, we also give melatonin. And all those drugs have been shown to decrease pain and nausea by using opioid-sparing analgesia. Now, with that, we have a lot of less pain. So the patient you saw sitting in front of you had very little pain post-op. But if you have pain, we still use narcotics as our rescue drugs. And so you will have a pump of your own narcotics. In addition, besides the pump, the nurses will have orders for tablets as well as injections of Dilaudid narcotic pain medicine.
And it was propofol and
Remifentanil, which is narcotic that only lasts for a minute in the bloodstream. When some of the Swiss researchers were inventing this new narcotic, several died because they got little bits of it on the skin. It was enough to stop their breathing, and they were found dead in the lab. It's so powerful. Remifentanil and sufentanil was associated with several deaths when they didn't realize just how powerful low doses of it were. Does that answer your question about pain?